Hey there, welcome back to the Flex Diet Podcast. On this podcast, we talk all about things to improve body composition, increase performance, add more muscle, do it all without destroying your health in a flexible framework. Today on the podcast, we've got Dr. Chris Morrissey, and we're talking all about GLP-1 agonists such as Wagovi, Ozempic, etc. And what are some of the pros and the cons from Dr. Chris, who is also a fitness professional and a general surgeon, in addition to a whole bunch of other stuff that he's doing. So he has a very unique perspective on these medications. I will also link to an episode we did with my good friend Dr. Krista Reimel. Dr. Morrissey has been on the podcast before, so we'll link to that also. But I think you'll enjoy this conversation as we talk about some of the pros, some of the cons, what are the risks that he has seen. I also give my public service plug for what people should do if they're having symptoms. Go to the hospital, is basically get it checked out. But I think you'll enjoy this episode. And today we've got a sponsorship from Tecton. If you're looking for something to help with energy, and I especially been using it in the past with fasting. I find that having one of them in the afternoon during the middle of a longer fast, for body comp purposes, when I'm really focusing on body comp, I still do and work up to some longer fasts, as I talk about in the Flex Diet certification. And I find by adding some ketones, it really helps with this transition, especially when I'm transitioning back into those longer fasts. So if you're looking for an exogenous ketone that is an ester form, which means that it's able to raise your blood levels of ketones higher, check this out. I am biased because I am a scientific advisor there and an ambassador for them, but the taste is actually quite good. If you've tried any of the other exogenous ketones on the market, you know that they do not taste very good at all. Some of the salts can be okay, but they generally don't get your ketone levels very high. And now there's also products on the market that are just the free form BHB, or beta hydroxybutyrate, and I'm not convinced that those really make it past the gut. Maybe they have some effect, but right now I'm not really convinced. So as of now, the best form is the ketone ester, which is the form Tecton uses. They bind the BHB, which is the molecule of the ketone itself, to glycerol, and that enables it to get past digestion and into the bloodstream where it can be used. So check them out at the link below. We'll also include a code where you can save 20%. And then also we've got the Flex 4 here. Go to miketnelson.com/FLEX, the number 4. And in this episode, I asked Dr. Morrissey what his top 4 recommendations are for people who are using these GLP-1 agonist drugs. What are some things they should watch out for and things that will allow them to mitigate some of the risks and also improve their results? So you can find that at the link below. That exclusive audio is only at the link, and that also signs you up to the Daily Fitness Insider newsletter, where you get all sorts of other great information delivered directly to your inbox. So enjoy this episode with Dr. Chris Morrissey. Welcome to the podcast, Doc. How are you doing?
Good, man. How are you doing?
Good. We were just chatting before we hit record, and we're both complaining about how hot it is to train in the garage when it's super hot out.
Yes. Down in Kansas, it's 100 degrees today, so it's miserable in the garage.
Yeah. Do you find that it takes about 1 to 2.5 weeks to get used to it? This baffled me forever because I kept looking back at my notes because I've been training primarily in my garage, Christ, now for 14 years. And it took me 5 years to realize this. And one day I look back and I'm like, hey, wait a minute. It's almost like this time of the year. I started thinking, like, what the heck's going on? Was it travel? No. And so I went back and I historically looked at the temperatures around that time and the humidity. And I realized, I'm like, oh, so the years it would go, probably similar to where you are, low to moderate temperature. Then you get these spikes of sustained days that are hot, would just crush me. And then after a
Oh, yeah.
while, you got a little bit more used to it. I wouldn't say it's never fun, but it seemed to even out after that.
Yeah, for sure. Because like Kansas, it changes all the time. So like
Yeah.
July hasn't been that bad. It had been in the 70s and 80s for a couple of weeks, and then this entire week it's been 100, and it just sucks because it just feels like the air is heavy. I went out for a run the other day, and I'm like, oh,
Oof.
it's fine. And then I swear it climbed 80 degrees. I know it didn't, but it I got done. I couldn't breathe, and I hadn't ran that hard. It was just a zone 2 run, but. And then I looked and I was like, holy shit, it's 100 degrees out. This is stupid to even be out here running because it wasn't that bad when I started, but yeah, it destroys me. I'm much of more of a cold. I'd rather layer up and go to the gym and have the barbell be cold than it is. It doesn't get as cold as Minnesota, but I would much rather train in the cold than the heat. So
Yeah, the other part that always kicked my ass too is when we would go to Costa Rica. And a couple times I went down there in December and June, which are a little bit warmer. And the time we went down there in June was ridiculously hot. And it hadn't quite got that warm in Minnesota yet. So you go from, hey, oh, it's nice and cool here, not bad, to holy shit.
yeah, for sure. I've never been down there, but I'm sure it can be pretty dang hot. So
Yeah, it's just not bad though overall to complain about going to Costa Rica because of the heat, so can't complain.
right, for sure. Yeah.
Awesome. Well, I wanted to have you on to talk about some of the new crazy medications and because of your position there as a doctor, like some of the things that you've seen. Obviously, I'll link to the podcast. We had my good friend, Dr. Krista Reimel, on
Yeah.
here, or Krista Reimel. She's a nurse and has worked with these medications for quite some time, especially with diabetic populations. So she had a very nice perspective over many years. But for people who may not know you, just give us the brief background of what you do and then what you've been seeing, and we'll go from there.
Sure. So I've been on here once before. It's been quite a while though, but my
Yeah, it was
name's
a while
Chris.
back. We'll link to that one too.
Yeah, it's been, God, I don't know, a couple years now probably, but
Yeah.
my name's Chris Morrissey. I'm a general surgeon down in Winfield, Kansas, which is about 3 hours southwest of Kansas City and about 45 minutes southeast of Wichita. I work in a 25-bed critical access hospital, so not a very big place, but we kind of service a big area. I've been down here for 12 years. I did residency up in Grand Blanc, Michigan, then moved back to Kansas. I was born and raised in Northwest Kansas. I'm married and I've got 9 kids, ages ranging from almost 30 down to 8. So there's always something going on at my house.
I can
I did,
imagine. Is that just like a zoo? No offense.
but it's controlled chaos. This every day is different. I got 5 boys still at home that are going to be a
Oh man.
freshman down to the 3rd grade. So it's always something. I wouldn't change it. I love it. Some days are a little more frustrating than others, and boys are very creative and they fight and just do dumb things sometimes. But they're great kids. They like hanging out in the gym with me when I go out to the garage gym. So I have the lucky thing about that they'll come out and train with me. And I've been training in my
Cool.
garage for probably 6 years now. Built up a garage gym over the last 6, 7 years or so. But and then I also have a personal training side hustle. I don't have a ton of clients, but I do that on the side just because I like it. I also osteopathic manipulation at the new osteopathic medical school in Wichita. So I do a lot of spinal manipulation. I've taken some RPR classes, which I love. So I try to incorporate all that into my practice as well. So
And are you technically a DO? Is that correct? Or
yes.
you did both? I always forget on that.
So yeah, I'm a DO, so doctor of osteopathy. So we learn spinal manipulation in medical school. So we do everything MDs do. We take the same boards, same classes, but then we learn spinal manipulation on top of it. I did an extra fellowship, so I took a year off of school and just did that for a year. So I'd probably say 15% of my practice is manipulation. So I have people come to me just for that. More often than not, I do it on family and people I work with. Hey, can you crack my neck? Sure. Things like that. So, but it's awesome. It's a good adjunct to what I do. I'm not going to fix someone's gallbladder by doing OMM, but I can help with post-op pain and can do some other stuff with that. So,
Cool. As a side note, why do you think more physicians are not trained in that? I understand that it's a whole, I don't want to say different branch of medicine, but it's a whole different thought process that goes into it. But it seems like obviously you have to know what you're doing, but because physicians have a background in anatomy and physiology and all the medical stuff they take, it to me it doesn't seem like it would take that much longer to learn it and to get halfway decent at it to help a fair amount of people, especially when you've invested that much time and effort into the background. But maybe I'm incorrect on that.
no, for sure. We usually on average have about probably a couple hours of lecture a week and a couple hours of lab a week. So I think it's about 200 hours of extra just hands-on touching people, doing different things. Oh, yes, we do the cracking, we do like soft tissue, muscle energy, type of things, do a lot of articulatory things, and there's way more DO schools now. When I started, there was
Hmm.
only about 20, and I bet there's at least 40 to 50 DO schools now. So there's actually
Oh, wow.
more osteopathic physicians than there ever were probably, but it gets going overwhelming, and it's one of those things. Some people think it's woo and they doesn't think it works. I don't know. There's people just have different reasons for not doing it, but I would say the stats that I saw last is between 8 and 10% of all osteopaths actually use it, which I
Hmm.
think is sad because it's something
Yeah.
that we can do. And some people just don't feel comfortable. Some people, depending on what practice they do, they just don't have time to do it. I just make time. And it's one of those things where it's like biochem. If you don't study it, you don't get it. So you just have to practice outside of class. And some people just don't want to. They just want to focus on their grades, and they do the calculation med school game of, well, this is only worth 3% of my grade. I'm just going to tank this so I can do good on my, physiology test or whatever. You know what I mean? So it's just different ideas of what. But to me, yeah, I wish everybody did it because it's just a great thing. But I'm biased, so.
Yeah, and it seems like in Canada and Europe, it's a little bit different. Like I know some osteopathic physicians up here. That's literally like all they do, and they kind of had even a subspecialty within school. Where in the U.S., it sounds like it's becoming more popular, which I think is good.
Yeah, and actually, I don't know about all of Europe, but I know like in England, like if you're an osteopath, you're equated to a chiropractor. You can't
Yeah,
practice
it's more down that
medicine.
path.
You can
Yeah,
only do hands-on stuff. Whereas in the United States, like there's cardiothoracic surgeons that are DOs, and so you can be any type of physician you want. It's just a different credentialing. But yeah, in Europe and stuff, you're only a bone cracker. I don't think you can do much else other than that. So
got it.
yeah.
And then, yeah, so tell us more what you've seen in my little air quotes here, your day job.
Regarding the just in general, what do I do?
Yeah, just a background. What does an average day look like?
Yeah, sure. So like Monday, I'm in the office all day. So basically you'll see patients that either maybe need surgery or they're there for a follow-up or they're just having vague abdominal pain or something. So I see people in the office anywhere between 20 to 25 people a day. And then I have a wound clinic that I'm medical director of also. So I see a bunch of different wounds, venous insufficiency ulcers, arterial diabetics, surgical wounds, spider bites, whatever. Then I do a lot of endoscopy. So I do a lot of colonoscopies and a lot of upper scopes. That's kind of part of the more common thing that I do. And then I do acute appendicitis, take out gallbladders, bowel resections, do again a lot of wounds, a lot of abscesses, a lot of skin cancer removals. Kind of bread and butter general surgery is what they call that. So I don't do like pancreas or liver. I don't do thyroids anymore. I don't do breast because we don't have all the imaging things available to us. So just in the abdominal box minus the big scary organs, I guess you could say, is what I do. So and then, yeah, then I go teach 2 half days a week at the medical school, teaching manipulation to first and second year students. And right now, school just started back up. So I'm also a preceptor. So the third year students on their rotations come and shadow me for surgery. So I have 2 medical students with me. Actually, I got 3 right now that they just come and hang out with me and do stuff. So
Very cool.
yeah.
And related to the GLP-1 agonist, what have you seen from your perspective from, I would say just anything really, since you have such a wide background?
Yeah, so I want to start off by saying I don't hate GLP-1s. I'm not a complete anti-wacko that I think they're the worst thing ever, but because I really enjoyed the podcast with Krista, is that her name? Yeah,
Yeah.
I really enjoyed that. It was great. And I've seen it been very helpful for people, but for what I do for a living, one of the biggest things it does is it severely slows down gastric motility. So basically it makes your stomach so it doesn't empty. So thus one of the reasons people lose weight is they feel full and they don't feel hungry and they don't eat. Another thing that it does, it also makes the beta cells in the pancreas more sensitive to insulin so they can actually utilize it better. It slows down hepatic gluconeogenesis, so it stops your liver from making new energy. And plus, so that's kind of the way that it makes the insulin work better and that people lose weight. But then the bad thing about that is, for one, so if you come in with acute appendicitis and you're on a higher dose of the GLP-1s, then your stomach is so full, huge risk of aspiration pneumonia. Once you go to sleep to get intubated for surgery, you just can have a stomach full of food. So it makes it a lot riskier for that. Typically, if you come in for a scheduled case, you have to stop it for at least a week. Some places make you stop it for 2 weeks.
Oh, wow.
Um,
So that's pretty
yeah,
long.
yeah, it is. It's crazy. And it's because I've scoped a few people that were still on it, and I get in their stomach and they're just huge and distended and full of food. So
Wow.
I've seen it. firsthand going inside their stomach and seeing, oh my God, there's food that's been there for 2 or 3 days or something. So that's one thing that it does. And so we make them stop it. That way it just reduces the risk of that. One of the other mechanisms that it does is, so I don't know if you want me to get into how the gallbladder works and do all that
Yeah, yeah.
stuff. So your gallbladder is just a big sac that just stores bile, right? So bile's made in the liver. One of the biggest things that it does is it helps break down food that's higher in fat and also higher in protein. So on a normal day, your gallbladder's full, then you eat a meal, then from the duodenum, you get a little messenger called CCK or cholecystokinin. So it basically sends a signal to the gallbladder saying, hey, we got a bunch of food here, we need to break it down. So the gallbladder squeezes, a bunch of bile dumps out, starts breaking up the food, and you go about your day. So that's all fine. If your gallbladder isn't working, if you have what's called biliary dyskinesia, where basically instead of the gallbladder squeezing, it just coughs or like quivers and it doesn't really do its job, then you can get bloating, nausea, vomiting, upper abdominal pain, feeling full. So that's just the gallbladder itself if it doesn't work very well. So there's a test that we can do. So if you're suspecting gallbladder disease, the first thing we do is an ultrasound, look to see if you have stones in the gallbladder, looking to see if the wall is thick, like indicating an acute inflammation or infection, look to see if the common bile duct is dilated. Then if that's normal, but you still think the gallbladder has a problem, you do what's called a HIDA scan, which is a nuclear med test. Basically, they inject you with some dye. It goes up into your biliary tree, lights up the gallbladder, lights up the liver, and then they give you synthetic CCK, and they calculate your ejection fraction or how well that your gallbladder squeezes and empties. And so, for whatever reason, the normal number they picked is 35%. So anything greater than 35% is considered normal function. But if it's less than 35%, then that means your gallbladder doesn't work well. So in that case, typically we'd recommend gallbladder removal if you're having symptoms. But so back to the GLP-1s. So one of the things that they also do is it blunts CCK from being released. So then your gallbladder is actually sitting there static and not doing its job. And then they've seen over time of people that if they have biliary stasis, meaning the bile is just sitting there not flowing, increases the risk of gallstone formation. So if it's making your gallbladder sluggish, it's making your stomach sluggish, it's making some of the biliary system not work very well, then my theory is that it's causing more gallstone formation. So some of these people, I've been seeing more gallbladder surgeries, people that needing their gallbladder out, and like, oh yeah, a lot of them are on Ozempic or Wagovi or Manjaro. So now I don't think anybody gets scans or whatever before to prove that they had gallstones before. They may have had them before, but
Sure.
it just makes them more sluggish and make it not work very well. So I've been seeing that. Another thing I've seen is in the last 6 months, we've admitted 6 people alone with pancreatitis. And the only common ground I've seen in them is they were all on one of those medications. There's a long list of causes of pancreatitis. The most common is gallstones or alcohol. If you go on a big drinker binge or if you have a lot of gallstones, they can cause, because what happens is the stone sneaks out of the gallbladder, plugs up the pancreatic duct, gets that angry, then it causes pancreatitis. But these new medications have been shown to do that. And yeah, all the people that because I did a very thorough history and they weren't on any meds that would cause it other than either Wagovi or Manjaro or Ozempic. They had no gallstones. They weren't drinkers. They weren't smokers. They didn't get bit by a scorpion. They have all these weird things that can cause pancreatitis. So none of them had it. So again, I'm just postulating. I don't have 100% proof that it was that, but I'm seeing that. And like I said, we have a 25-bed hospital. So I don't have the patient population of New York, Chicago, all these big places that may be seeing more of it. I don't know.
And pancreatitis can be pretty nasty too, correct?
Yeah, and people can die from it.
Yeah.
There's an old score we used to use called Ranson's criteria. So basically, it's like a prediction of morbidity and mortality. They look at age, how high your blood glucose is, like AST, LDH, and then it's like calcium levels and all that stuff. So you got to do this calculation, and the higher the number, the more deadly it can be. But yeah, you can die from pancreatitis. It can be bad news. So, but yeah, I've just seen that since like December or January, and only half the year. And so again, I might be wrong, but I have no other proof. But that was the only thing that to me that I could show that was the cause was that. So I don't know. We'll
As
see.
a side note, what are some of the symptoms of pancreatitis? I feel like I need to do a little public service announcement
Yeah.
because most guys will put up with horrendous like pain in their gut and not go in, and you just need to go in. But
Absolutely.
it comes better from you than me.
Yeah, no, for sure. So one of the things is you either get like mid-upper gastric pain. So there's like kind of three, if you want to nerd out and go back to embryology,
Yeah,
there's three embryologic pain zones of your gut. There's like the mid-epigastric region, the periumbilical, which is around your belly button, and then the suprapubic, which is above your bladder. And then from embryology, the way the gut develops, you have your foregut, your midgut, and your hindgut. People may or may not remember that from biology or anatomy, but so in the foregut, basically it's going to be esophagus, liver, stomach, gallbladder, pancreas, duodenum. So if you have pain up here, then that can be any of those organs. So you got to sift through and figure out what the cause is. Or the periumbilical is going to be your midgut, which is all your small bowel, your appendix, and the majority of your colon. And then the suprapubic area is your hindgut, which is basically descending colon, sigmoid, and upper rectum part. So based off where they'll have vague abdominal pain right here, and it just feels like someone took a spike and shoved it straight through, right out through their back. And that's a big hallmark of that. Nausea, vomiting. Anytime they eat, they just feel sick. They feel bloated. It's just horrible pain. So that's in it. Again, it can be more than pancreatitis, but that's
sure.
the main thing. And then based off history and physical, we'll order the appropriate imaging, either CAT scan or ultrasound and lab work. And then if you get diagnosed with pancreatitis, the big treatment for that, number one, remove the offending source. So if it's gallstones, take the gallbladder out before they go home. Alcohol, you quit drinking. Medications, you stop the medications. And then basically fluids, don't let them eat or drink, and just hurry up and wait for the pain to get better. But it can take a few days. It can be in the ICU if it's really bad, and just flooding them with fluids for days sometimes. So
While we're doing our side note, little public service announcement, explain where the appendix is on which side. And because I think I've had a couple of people that not recently, but have had pain in their side, and I'm like, isn't that the side where your appendix is? Like, I think you should go get it checked out.
right. So almost always the appendix is on the right side.
Right. I know there's
So
some weird stuff, like even cardiac stuff you can. I saw a case once of dextrocardia where the
yeah,
whole cardiac system was literally flipped and backwards, so to speak. So there's
yeah.
obviously weird anatomy stuff that can happen.
Yeah, for sure. So one up from that is called total situs inversus, when all of your
Oh
organs
yeah,
are flipped.
flipped.
So I saw one case of that in residency. It was a 16-year-old kid came in with appendicitis, but he had left lower quadrant pain. And so looked at his CAT scan, and we were like, is the patient upside down? Everything's backwards. And then we were like, oh,
Oh,
they've got that. So when we went in the abdomen, yeah, the liver's on the left, the spleen's on the right, like everything is just
wow.
a mirror image and flipped.
So
So
wild.
unless you have that,
Which
or
is
one of
very
the
rare.
other, yeah, super rare. I don't know, less than point something percent. The other thing, if you have what's called a midgut volvulus, where basically as you're developing in utero, all your guts herniate out through the belly button, they twist around and they go back inside, and then they take up shop where they're supposed to be. Sometimes they get inside and they get twisted some, but they don't go where they're supposed to be. So all of your small intestines is clear on the right side of your body, and your entire colon's on the left. So instead of the colon framing the abdomen, the colon is all over on the left, and so your appendix can be in the left lower quadrant too. Seen that twice. Otherwise, almost always the pain's in the right lower quadrant. So usually it'll start in the belly button, be just vague, and then migrate down to the right lower quadrant, get really sharp, hurts going over bumps. You have to hunch over to walk, depending on where the appendix is located. So yeah, if it's right side of pain, like it depends on where it is. If it's on the side, that could be like kidney stone, or it could be pancreatitis too. Just depends, but yeah, right lower quadrant, almost always appendicitis. So for sure.
My last little public service announcement too is that I've known two people in the last year who all of a sudden had like abdominal pain and went in, and I guess part of, I don't know if it was I think it was their small intestine, but maybe it was the large intestine, got actually twisted and started cutting off the blood flow to it. And both of them had like emergency surgery. Luckily, they both went in like right away when they had just debilitating pain, and they were okay. But that was it. None of them had symptoms beforehand. They're just walking around all of a sudden. And like, that's bizarre too. But
That's pretty rare too. Your GI tract is one long tube, right? It starts in your mouth and it exits at your anus. But and as your bowels are moving, it's just like a plate of spaghetti. The small intestines in the middle are always moving, and sometimes it just takes the perfect storm of it kinks weird, kinks a different way weird, blood supply's cut off, and then it just gets all swollen, and then blood can't get in, blood can't get out, and then the tissue starts to die. On average, you say if you shut off blood supply to something, you have about 6 hours to get in and relieve the obstruction, whatever it is. If there's a clot blocking off the blood flow, if the gut's twisted, after that you start having tissue necrosis and the tissue starts to die, and then you might have to do, depending on how much is involved, a bowel resection, take out part of the small bowel, take out part of the colon, And just a little side note on that is you can completely live without your colon. You don't need your colon at all. So if you get a little bit removed or all of it removed, you can live without that, but you can't live without your small bowel. So if you get so much of your small bowel taken out, you get what's called short bowel syndrome, where you basically can't absorb anything and you're like on chronic TPN, which is IV nutrition for life, because you can't do anything because you have no nutrients to do anything with it. So that's a big deal. So some people think if you lose your colon, oh my God, it's terrible. Well, it is. You'll just have diarrhea, but you can live without your colon. So
Yeah, people may remember John Meadows, rest in peace. So I miss John a lot, but he didn't have a large colon for many years. I mean, he obviously had some digestive issues. He was okay otherwise. So
yeah,
it's not something that's high on my list, but definitely something you can still get by with.
yes.
Or
Try to
without, I should say.
keep it if you can, but
Yeah.
if you have to get rid of it, it's not the end of the world.
Well, thank you for the public service
Oh,
announcement
sure.
there. Because I had one case, oh God, this is probably 11, 12 years ago. A client texted me and said they were having lower right abdominal pain. What should I do? And I'm like, don't call me. Go to the ER. What are you doing texting me?
Right?
Yeah.
That's funny. Was it appendicitis?
I think it was actually,
Yeah.
yeah. Yeah. So luckily they went in. I'm just like, oh God. Yeah. So if you have any medical emergencies, like just go in, get it checked out,
Yes.
do the thing. Especially most people know when they're having really bad pain, right? It's not, oh, this might be just a little bit of indigestion. Most of the time you know, and it's still astonishing to me that some people are like, oh, it'll pass. I'm like, bro, you've had like blinding pain for 6 hours now. That's just, I don't know what it is. I'm not a doctor. It's not normal, but for God's sakes, get it looked
Right.
at.
Yes, for sure. And some people they go to the ER too much. Some people every little
Oh,
thing they go
definitely.
in, but yeah, it's sometimes you get all ends of the spectrum, or someone's had this growth go for 13 years and they come in and it's like this ginormous thing they want removed and whatever. So it's weird what people will put up with sometimes. So
Yeah, check
it's
out my
crazy.
goiter.
Yeah, exactly. For sure.
Well, back to our topic on hand here.
Yeah.
Is there any screening that are done for these drugs? I've heard everything across the board. I have some friends who are physicians who prescribe them who seem to be pretty, I would say, good about who should use them, who should not, describing the pros, describing the cons. But then I know of, it seems clinics, spas popping up all over creation where they're just being handed out. And now I think one of them, I can't remember, an early one is off patent. So you may be able to find it on certain, maybe scrupulous, non-scrupulous websites. And it just seems like me, it's all across the board in terms of, hey, here you go, or let's actually have a discussion about this. Here's the pros, here's the cons. It seems to be all across the board from what I've seen on my end.
Yeah, so I think if physicians are doing it more often than not, and I don't know a lot of physician friends that are prescribing it, but they usually do a pretty good job at, you want to just do obviously complete history and physical exam. One of the big red flags is it can lead to medullary thyroid cancer. So if you have
Hmm.
a family history of thyroid cancer, or if you have enlarged thyroid or any other symptoms like that, then you may want to have second thoughts about maybe prescribing that for people like that. There's some endocrine like MEN syndromes, which is multiple endocrine neoplasias, where they can get different tumors in different places. So people like that should probably not have it. And again, I don't prescribe these. I'm just saying what I know. Otherwise, you should get some blood work, just normal, like complete blood count, checking your electrolytes, liver numbers, kidney numbers, just to start with to get a baseline. And then probably, I don't know what the algorithm is. I know they start off usually 12 and a half units on most of these. Most of them, almost all of them are a weekly injection. I think Manjaro's daily, but I want to say
Yeah,
Wagovi and Ozempic, I think, are weekly. So they'll start off at 12 and a half and they slowly ramp up. And interestingly, I just listened to your repost of a podcast, Dr. Andy Gelpin and
the
Dr.
Ryan Green.
Green.
Yeah,
Yeah, I just listened to that and they mentioned it. I think you shot it back in 2021. So
right.
some of it was new. It was interesting timing that we were talking about this, but
Yeah,
they were talking about it too. But yeah, you definitely want to get one of the biggest things you'd want to get a baseline is a hemoglobin A1C, which is like your 3 month long blood sugar average. And then, because most of the time, if you're using it for diabetes, they're going to be high. And so then you want to recheck that at probably 3 month intervals. Also checking liver numbers and kidney numbers, making sure those are all in check. And then just check in with them every so often. Again, I would probably do it maybe 1 month in just to see how things are going, and then probably the 3 month and a 6 month mark. And I've heard protocols about people cycle on and off of them. You be on it for 6 months and then you go off of it for a short period of time and then go back on them again. I don't have long-term data on that because I don't prescribe it, but there's a lot of places that pop up that you just give it out just because it's cash and there's no follow-up, there's no anything, and that's one of the things I have a problem with for sure.
Yeah, that bugs me with just about anything. It's
Yes.
especially any medication, drug, there is going to be pros and cons. There's nothing is side effect free. Christ, you can die from hyponatremia from drinking too much freaking water. Like
Right?
you have to try pretty hard to do it, but unfortunately, people have done it. So
Yeah.
even water is not without its risks. So do your homework. If you're going to a physician who is just like, hey, here you go, you'll be fine. Ask some questions, maybe go to a different physician. I wouldn't say Google it unless you're trying to Google questions to ask your actual physician. I wouldn't trust
Yes.
Google for medical advice at all.
Yeah.
But it just seems like people want to believe that there is no cons to anything. There's all just
Right.
pros. And I get it. Like I tell people, like just listen to any pharmaceutical commercial. Like it's all happy, it sounds wonderful. And then if there's a laundry list of side effects that are most of the commercial, again, doesn't mean that's not beneficial, doesn't mean that some people can't benefit from it, but
Right?
there's going to be some risks involved too. And so work with someone to make an educated decision instead of, well, I just need to lose 10 pounds, so I'm just going to do this for a couple weeks.
Right. Probably not the best idea.
No, not the best idea.
Yeah.
And then also, from a risk perspective, I'm just trying to think. So I won't say who, but a friend of mine is a nurse anesthetist, and she's seen some surgeries that they've actually even had to put out because they go through the list. They ask them, hey, are you on any medications? Are you on anything? No. And sometimes they don't find out till they're wheeling the person back. Or like you said, sometimes they don't find out till they're actually in there. So I guess my last little public service thing here, I feel like I'm lecturing at people, is
No.
tell your physician and people in the hospital setting, like what the hell you're actually doing. They're not going to arrest you. They're not going to be mad at you. They're not going to hopefully give you a lecture for an hour about your decisions. But for God's sakes, tell them what the hell's going on. It's my last little public service.
Yeah, and to counter that is I've started asking in my office every person, are you on any medicines? Like I'll ask about blood thinners and I ask about GLP-1s, just on
Yep.
everybody, colonoscopy, gallbladder surgery, whatever, because some people look at those medicines as supplements.
Right.
So you look at their med list, and I always, are you still on all these meds? And I'll list them off, and then I'll say, are you on any blood thinners, any aspirin, Plavix, Coumadin, Xarelto, anything? And then are you on any of those new weight loss medicines like Wagovi or Manjaro? Oh yeah, I'm on Ozempic. I'm like, okay, so that's not on your list. And then I have to tell them why that's important for them to know. But at our place, so I usually have my nurse will go in and room the patient and ask some questions. So she always asks. Then I send a medical student in to do the interview to get them practice. I make them ask. And so there's 2 times of them to tell them. Then I go in. And then the day before a surgery, one of our nurses from the hospital calls and they'll ask. Anesthesia asks the day of. And then sometimes
Yep.
it'll get through. They say no to my nurse, no to my student, no to me, no to the nurse. The day of surgery, they'll be like, oh, yeah, I'm on Plavix to the CRNA. Well, yeah, duh. And well, did you stop it? No, no one told me. 4 people asked you, and you said no every time until the day of surgery. So that happens too. But yeah, I had a lady I was set up to do an upper scope on, and I asked her about medications, nothing. The day of, they're like, we're canceling your scope. I'm like, why? Oh, she's on Ozempic. I was like, didn't tell me that. And I asked her, you know what I mean? So it's some people just have no clue what their medicines they're on. They just like, oh, you should have that information. I'm like, well, I do, but I want to make sure that's right because sometimes meds change or
Oh
they don't
yeah.
take them or whatever. So yeah, it's a lot of, hey, help me help you. And yeah, we do a really good job at asking multiple times and still miss things, I'm sure. But yeah.
Yeah. Do you think there's some variability, like all things, between patients in terms of transit time? Like you may have some people, like you were saying, it seems like they're pushing out the time longer now to potentially accommodate maybe some of those people who are on a higher dose, or maybe they're just weird hyper responders to it, perhaps.
Yeah, I think that's part of it. And when some people if they're really bad diabetics, and they can get diabetic gastropathy, where
Yeah.
basically their stomach is slow to empty anyway because of the nerve damage from diabetes. And so those people may have severely slow emptying times, but we don't do like a gastric emptying study to see how slow their stomach is beforehand. And so, yeah, I think some of the other medical comorbidities definitely can make it challenging to know how far out. So in general, we just do a week for everybody, unless there's another reason why we have to make it longer. But that's what we're doing at our hospital, I think, because we get nurse anesthetist students from KU, and they rotate with the CRNAs here. And I think they said at KU they do 2 weeks
Hmm.
of the GLP-1s. And so it just depends on where the protocols are. But on average, I want to say it's a week here. So
What do they do in the case of if someone needs an emergency surgery? Do you just have to work around it at that point and just deal with the lesser of two evils?
yeah, so basically, if they have a perf appendicitis and they have to have an operation, we basically say, hey, look, you're on this medication, whether it's blood thinner, whether it's, Ozempic or whatever, like this is going to make the surgical procedure a little more risky because of this. And just letting you know that. So if you do end up with aspiration pneumonia, that doesn't mean we're just like have a free pass to do what we
Right.
want. But we're just like, hey, just so you know, because of this, you have a higher risk of having this done to you, just so you're aware. For where we're at, if it's going to be too risky, like if they're on 3 blood thinners and we have a very limited blood bank in my hospital, we don't have platelets to give if we need to give them platelets. So sometimes we'll just ship people out if it's too risky and they have to go somewhere else. But yeah, if it's an emergency, they will die. Well, you got to, again, lesser of two evils, and just hope everything goes well. So
Yeah. And I think some blood thinners you can reverse in emergency circumstances, but I don't know of anything that you could reverse any of the GLP-1s. You're just, but it is what it is at that point.
yeah, to my knowledge, there's no reversal agent. It's just you have to leave it out of your system. And so 6 hours is not going to get it out of their system. You're just stuck dealing with it for sure. So
And shifting gears a little bit, as obviously you do stuff in the fitness area too, and you have a
yeah.
background with medicine. What are your thoughts about, from a fitness side, some of the risks of these drugs? And I'm thinking more in terms of like habits, and in some of the original trials, we've showed people have had lean body mass loss and things of that nature.
Yeah, so it's a great question because I was wanting to talk about this too. There's a lot of people around here that are on them, and you can always tell they get a lot of proximal muscle wasting. So like
Mm.
their shoulders, thighs, they almost look atrophied to me. Though their face looks slimmer and they definitely have lost weight. Their clothes are different sizes, but you can just tell that they have just a lot of muscle wasting. And my theory is you're in a catabolic state all the time. And so you're not taking in fuel. So let's just start taking away muscle. Like people that are on third world countries that are starving and they get all cachectic, or people that are anorexic, you just start tapping into what fuels you have in your body. And so I think it's a big problem. And this is a big reason why I'm against these medicines for weight loss, is because most people aren't going to, they just want the easy button because, by nature, we're all lazy, right? I mean, I'm not saying only people on Ozempic are lazy. Like we're all lazy. We want to do the easy way
Yeah,
out.
your
But
body is programmed for efficiency. That's just how we're programmed.
yeah, absolutely. And conserve energy when you're not doing anything and
Yep.
expend it for when you need it. But I have a problem with it because I'll have people come to me and I want to lose weight. I want to do all this. I'm like, can you prescribe me Ozempic? I'm like, no, I don't do that for one. I was like, if I will consider doing it for you, you have to show me you're committed to at least 6 months of sleep, nutrition, movement, doing all these things, resistance training. And then if you're proven, because the medicine doesn't shift your mindset, you're not changing habits, you're just like injecting and can eat still whatever you want. So that's why I have a big problem with it. And so I feel that if people are on it, they should be being sent to someone that does personal training, or if the person that prescribes it can do it, just so you don't get the muscle wasting. Because I don't know, I feel if you're tapping into muscle stores, then if the people are older, maybe they're getting more osteoporosis. Maybe we've seen the bone density increase from resistance training is awesome. So if you're not resistance training, I think you're robbing yourself of all of your fuels in your body. And so I have a big problem with that people don't want to. But if they're like 100 pounds and they just barely can move, I would be for that. Say, hey, this is what our plan is going to be. Maybe give it to them to get them a jump start, put them on an off cycle, make them start exercising when they can move better, and then they can go back on it. But they got to show, to me, you should show commitment in you're willing to change instead of just, I just want a shot and go to Sonic and whatever.
Do you think people will choose to stay on these medications? I've heard that there's some early literature showing that the average time, I think, was 6 months. I haven't read that yet. That was from a friend of mine. But do you think people will just choose to stay on? Because my fear is exactly what you said. Bob, whose butt looks like a couch cushion. Oh, I heard I can just get on Ozempic and lose weight. And on one hand, it boggles my mind that we actually have medications that are that effective that we're actually worried about crushing your appetite too much. Like if you would have came to me like 3 years ago and said, we're going to have these new drugs, they're literally going to crush people's appetite so much that they're going to have all these kind of wasting conditions from it. I would have said, no, you're crazy. That appetite is so redundant, the need for energy, all this stuff. And holy crap, like that's where we're at now. But do you think people will choose to stay on them? Because my guess is they'll go off. They haven't made any lifestyle changes. So they haven't really learned anything about what to do differently. Shocker, they'll probably gain weight because they're going to eat more.
Yep.
And then maybe they just decide to go back on again and they're on this kind of weird yo type thing, but they're potentially losing a lot more lean body mass as they're doing it and becoming less functional.
Yeah, for sure. I think they will, and I think they'll just see the results of that they've lost weight, and now they're happy. And oh my God, this is awesome. And then they go off it, and they cyclical depression cycle of, like I said, binge eating, and then they'll go back on it to lose weight. And then over time, are they going to be losing a lot more lean muscle mass, like you said? So I feel the people that don't want to do any lifestyle changes, they'll just keep doing it as long as people will give it to them. And if the clinic they go to quits doing it, they'll go find somebody different up the road because I'm sure you can find anybody to do anything if you keep looking hard enough. So yeah, I foresee that being a big problem. And it seems like my short career as a physician, I've been out of residency for 12 years. So I've been a doctor for 17 years. It seems like every drug that comes out that is awesome, then they pull it later because it has all these problems. So
You
that's
mean
just my
fen-phen?
prediction. Huh? The
I was
what?
thinking of fen-phen.
I was thinking of fen-phen and Vioxx, the big anti-inflammatory drug back in the day. Like every drug that's like the best thing since sliced bread, it always ends up getting pulled, and or you'll see every other commercial of lawsuits for being on their medication causing problems. So that's just my prediction. I'm probably wrong, but it just seems if it's too good to be true, it usually is. And so, and also too, I've read that we're having trouble getting it because so many people are using it for weight loss, and then the people that are diabetics that really need it can't get it, or that we're price gouging so bad. Because I think
Right.
in the US, I think an average month is like $1,500, and then in Europe you can get it for 110 or something.
Yeah,
So
I don't
like
understand that.
the US market is just crushing it with price inflation, and it's one more thing that we're having go wrong here. So yeah.
If if you were in charge of, say, these drugs and somebody came to you and said, okay, let's throw the psychology out the window for now, which again is a huge topic. But just based on the physiology, and they said, okay, you're in charge, people are going to request these drugs. What would be your requirements if you were to prescribe them in a perfect world just based on physiology?
Are we doing it for weight loss?
For primarily for weight loss, because I think
Okay.
that's obviously diabetes is a whole sub issue, but
Right.
I think the weight loss is where I'm more concerned because it's people not necessarily, yes, it's a medical condition, but I think there's this huge oncoming flood of people who also just want to lose 10 to 30 pounds.
Yeah, for sure. So what I would do is I would probably treat them like any of my either like regular patients or personal training clients. I have this big intake form and make them fill out goals. What have you tried before? What's your eating habits? What's your sleep like? What have you done before? And then I would lay out an algorithm I would calculate based off ideal body weight, not their actual body weight, of what their macros need to be. I would set up a nutrition plan. I would set up mandatory at least walking 5 days a week and maybe 2 days a week to start off with, some sort of resistance training, just even getting a gallon of milk and kettlebell swings or curls or something. So I would make them do that. I would make them do weekly check-ins. And if we're in a perfect world where I can do whatever I want and they'll comply, I wouldn't give their medication until they show me either video evidence or a step counter. Send me your Oura Ring data, send me your Garmin data, and to show that you're actually putting in the work. And then you can here's your medication to make them compliant. Because otherwise, they'll just do it. They're like, yeah, whatever, just go to an injection. Oh yeah, I worked out. Yeah, how'd that go? Oh, it was great. And yeah, I just that's what I would do to ensure compliance. Because again, I'm for these drugs for the right reason, and but you have to have everything else dialed in, just like everybody else says, to make things work. Just sleep, nutrition, habits, and just I got some of my philosophy from you, but I've always been big and low and slow. Just say, okay, let's change this one thing. Let's just start walking. If you don't do anything else, just start walking 6 days a week. And once you've done that for 3 weeks, then we'll move it up to let's look at your protein intake or whatever they can do. Because I'm a big believer, and that's helped a lot of my people that I train is instead of having, okay, you have 10 things to fix by tomorrow, because then they won't do it. It just seems to be the best way to do things. So that'd be my perfect world thing to do. So
Nice. Do you think there is some other, I wouldn't say really a side effect, but maybe some other effect on muscle mass directly from these medications? Or do you think that they are such a potent anorexic that they're just crushing appetite so much that most of the population who is using them are not going to be resistance training or are not really going to be consuming much protein?
I think from what I know, and I haven't done a deep dive into the nuances of it, but from what I've read, to me, that just makes sense that it's just from sheer malnutrition from not eating. I don't think the medicines are actually like breaking down your muscle itself. I think it's just your body needs fuel, and I think your body's doing it. Again, that's my theory. I might be completely wrong, but that's just what I think the problem is. You just because again, you get big and bloated and distended, and your hunger mechanism shuts off, and you're like, oh, we don't need to eat, and then we start mobilizing that, secreting more insulin and getting more insulin in the tissue. You start burning more fat, and then you run out of fat. So now you got to go to the muscles or whatever. So that's what I think it is. That so.
Yeah, I had the idea, which this probably wouldn't work, and I definitely couldn't make any claims on it, but someone I'm sure will do this, and maybe it's already out there, of the Ozempic supplement, and it's basically just essential amino acids. And all you do is you just mix them in water because people, even taking protein sometimes for these people can be very difficult. And even a protein shake, which isn't really that much, in some cases I've seen anecdotally can be too much.
Yeah.
So I would make it just literally free form essential amino acids that are like water, and you have to consume it 3 times per day. Again, is this an ideal situation? No, but someone's probably going to do that, and it probably would be helpful to some degree versus nothing. What are your thoughts?
Yeah, I mean, I would think something's better than nothing, but it's hard when if you're like you're like, I am not hungry at all. I don't know if you're trying
Right.
to doing a bulk on is I don't want to eat anymore. I'm tired of eating, but then making yourself eat, you just probably aren't going to do it. So I could just see people being like, if you can't get them to get up and walk, I don't think they're going to force themselves to be like, oh, I got to drink this stuff again. I'm just not going to do it. You know what I mean? I think it would be helpful. I think some's better than none, but I still don't think globally it would probably help much. I'm sure if you're selling a supplement, yes, you're going to make these claims that it's going to keep your muscle mass and do all these things, but uh, I just don't see a lot of people doing that just because you don't feel like doing anything. So,
My other thought was that the pharma solution, at least for guys, will just be TRT replacement. Because like pharmaceuticals tend to think of the solution as always another pharmaceutical. Oh, so what other pharmaceuticals do we have that are massively anti-catabolic, at least in men? Women's a whole separate issue. Oh, testosterone. So I just have this weird vision of TRT Ozempic clinics like popping up everywhere for guys.
oh yeah, especially when people are doing like the pellets, they'll probably start doing more of the
Yeah.
pellet stuff just to sustain all that stuff. And I looked into doing some of that, and because I'm a medical director of a med spa too, and we were looking at longevity things, and I got on some like endocrinology message boards and went down a couple rabbit holes, and they're seeing so many things, so many more disease processes than they've ever seen before, just because of the hormone replacement things when they're just running just clinics to make money. If you have a true problem, that's a different story. But I think I would say a lot of the people that are getting it, that, oh, I got low test, it's probably don't. You just want to legally obtain anabolic steroids and get them in pellet form or whatever. But yeah, I just like, I don't want any part of that because it just seemed like it was just a whole bunch of problems that are evolving that I don't want to be a part of. So,
Was
yeah.
that more with the pellets, or was that with people going probably above the physiologic range with testosterone?
They weren't like specifying of what they were
Mm.
seeing. It was just in general. I was just like, because I think I Googled, I don't know, endocrinology message boards with hormone replacement. And then I got on all these chats with people. I wasn't like physically chatting, but just
Yeah, yeah.
oh, I'm seeing way more thyroid cancers now. I'm seeing all these weird metabolic problems and all this. And I think the common theme was people being on TRT. And again, not hating on that either. But I just, sometimes I think people that are just doing it to do it that aren't really, don't slow down and try to calculate what they need. And just, oh, this is the algorithm. This is what we're going to do. And I think that's where we get into trouble. So yeah, I didn't see them specify pellets versus the actual injections or whatever. So I'm not really sure.
Yeah, I feel like whenever I get that question, I spend most of my time trying to talk guys out of it because it's usually never the question that I get that's the person that's done their homework that probably is legitimately low or they're getting older, whatever. It's the 28-year-old whose testosterone is like 350 and you're like, bro, you sleep 4.5 hours a night. You're trying to train 2 hours a day. You're stressed out of your mind. Like you're chronically undereating. Like you barely get enough protein. Your micronutrition is a disaster. That's, hey, yeah, I get it. Like your testosterone was low. That's not really a shocker.
Right. And so I feel that's the same way with the Ozempic. It's just, well, I don't want to change my stuff. I just want to take this thing and get so I can feel better and do whatever. So it's a similar theme of I want to do less work and get more things out of it is what it comes down to, I think.
I heard a statistic, and I don't know if this is actually true or not, but I think this class of medications are the most successful pharmaceuticals ever, I believe. Like I think total gross was close to $1 trillion, I think. I don't know
We're
if those stats
talking
for
about GLP.
GLPs. Yeah, GLP-1s.
I think I saw that it was like either I think last year it was like maybe it was like, I don't know if it's ever, but it was the highest grossing sales last year. I know for sure, but I don't
Maybe
know.
not
It's
ever,
kind
but maybe it was last year is what I was thinking.
Yeah, I saw that the other day just because there's so many clinics popping up and there's people in my town that do it. There's people 2 towns over that do it. And they're just having so many clients because people are just coming in. They charge them $600. They get a screening of some sort and their first injection and they're out the door. And then they're getting like 60, 70 new people a week. So yeah, they're definitely handing it out. Whether it's all needed or whatever is a different story. But yeah, I would 100% believe that.
My next thought then, if I was trying to be super optimistic, maybe people are looking for performance enhancement more than ever before. Like longevity is becoming a more popular thing. And on a good day, I keep thinking, well, maybe some of these people will be more vested in their health. And maybe if they lose some weight, maybe that's what they need to kickstart their healthy habits and they can exercise more. Maybe they'll hire a trainer and they'll do all the wonderful stuff. And then on days I feel really negative, I'm like, no one's gonna effing do that. They're just gonna take drugs.
I like the optimism in the first statement. I think the second statement's a little more accurate because obesity is higher than it's ever been before. And so that I just think it's because we eat crappy food and we don't move. And social media and screens have killed a lot of things. You're seeing, I know when I was a kid, there was only like a couple obese kids, and now it seems like they're everywhere. And the fact that we're getting softer as a society, I think there's just this huge conundrum that we're just feeding into the wheel, that we're not helping things. But yeah, I really feel that in theory, you would think that people would be like, oh, I'll lose weight, then I'll start working out. But it's 50 pounds. I didn't do anything. Why would I do that? I don't want to go to the
Hmm.
gym. I don't want to do this extra stuff. I'll just keep taking these shots. So it's the easiest way out for sure.
Yeah, my negative days, that's what I keep thinking is that humans are so programmed for efficiency. And when something works, it's easy to, I think, sweep the costs under the rug. So one of the little things I had on my checklist is if you're prescribing Ozempic, like you have to do DEXA scans on all your patients, right? So you have
Yeah.
to physically show them, okay, here's where you started. Hey, this is great. Like you lost 20% body fat. Oh, by the way, 40% of that was lean body mass. To me, it should be some type of requirement that you should inform people of what's actually going on in their physiology.
Yeah, for sure. And you might tell people that don't work out that they don't care about their losing muscle mass. Well, I don't want to get big.
Right.
I can see them doing that and they don't care, but they don't realize that how important that is for just well-being, that it just like, oh, I don't care, whatever. Weight's weight. It doesn't matter. So yeah, I think that'd be a great idea, is the DEXA scan thing for sure. So
Because I think there's something empowering about seeing your own data versus somebody telling you what's going to happen or what even did happen. Like I use this HRV all the time. Like I used to have before I did HRV. Oh my God, I don't know how many discussions about stress I would have with people. And now I'm just like, hey, look at this. And it's a little thing that shows their stress going off a cliff. I just graph it and send them a picture and go, what do you think's going on? And they're like, oh my God, I didn't realize I was that stressed. And from the outside, it's easier to see than when you're experiencing it. So I think using data, hopefully in something like that, might be useful to better inform people again about what are the pros and what are the cons.
Oh yeah, absolutely. I'm huge on if I have personal training clients, I make them do measurements of arms,
Yep.
hips, thighs, and then weight, and then they weigh every week. And then I have them do it again after 3 months and do a little maxing out, depending on if it's weight or just body weight stuff. But just to show them, because they may say, oh, I don't think I'm doing anything. It's you've lost like 25 pounds in 3 months and your lifts have gone up and all this. So they just don't see it because they just look at themselves every day and they don't feel different. But it's so you can objectively show them that, yeah, you made huge improvements. And just like with the weight loss thing, yeah, before and after pictures or DEXA scans or calipers or whatever you want to use, at least to show them they're making progress. And hey, this is how we need to tweak this, and always, changing. That's okay. Let's start adding more resistance training because you're starting to lose more body mass or whatever. And then if they decide they don't want to do that, then to me, if it was my patient, I'd be like, all right, well, you can go find a different provider if you're not going to put in the extra work, because I don't want to just give you meds to do nothing. So,
Yeah. Awesome.
yeah.
And last question, unrelated. Any good music you've been listening to? Side note, did you see Gojira at the Olympics, which is pretty phenomenal?
I did not see that.
I had to watch it on video, so.
I haven't seen that, but I heard that they were there and I heard it was awesome. Yeah, lately I've been on a deathcore kick, so I've been
Ooh.
doing like Slaughter to Prevail,
Oh yeah.
Upon a Burning Body,
Yeah.
Skinless. So that's been my, I don't know, last 2 or 3 months. That's been on my go-to. I'll just get on Apple Music and hit one of those stations and just listen to that all the time. So that's been my jam lately. So
Yeah, the guest vocals he did on the, what was it? I want to say, was it Falling in Reverse with Tech Nine? The,
ah,
I can't remember. Ronald was the name of the song. So
yeah, I
that
heard
was
that
pretty
recently.
cool.
That was
Yeah, that was one of
awesome.
my new favorites. And the new Upon a Burning Body song with a lot of the clean vocals and stuff in it. I think it's Ghost. That's one of my new favorite songs. It's just such an awesome song.
I don't know if I've listened to that one yet, but I'll
And
have
the
to check
earliest
into
stuff is
that.
great too.
I just those are some, they sound similar. I know they're different, but I'm not as good at, like, back in the day I can tell you album, you know, artist, song, but nowadays I just don't care as much, and so I just hit one of their, I'll just put shuffle and I just listen to them, and so I couldn't tell you, oh, this is on this album. I can do that with Iron Maiden, Slayer, Pantera, all that
Yeah, yeah.
from back in the day, but all the new stuff, I just like the sound, so I couldn't tell you what's on what, but there's some really good ones though that I've heard lately, so
Nice.
yeah, for
Nice.
sure. What about you?
Oh man. The new Mushroom Head sounds interesting. I've only heard 2 tracks so far. We're going to see Metallica coming up here in a couple of weeks with Five Finger Death Punch and Pantera. That's gonna be
Really?
pretty awesome.
Oh my God.
Yeah, I'm so excited. I did get tickets to see Lorna Shore. They're headlining at the Fillmore, which is a very small venue. And I was so bummed because initially tickets went on sale and they sold out like instantly, and basically a bunch of scalpers bought most of the tickets.
Oh,
And so the band was actually super cool. So they were able to acquire some more tickets. So they tried to release them in more random, sporadic stints to prevent people from scalping them because they were reselling them for $450 a ticket. I was like, what? I'm like, I'm
whoa.
not paying that. So I
No.
got tickets to see them. They're playing with, I'm liking now, Sonia Sugabog and Kubla Khan. And there's 2 other bands there too.
Oh,
So that'll be pretty good. The new
that's
Kubla
awesome.
Khan is actually really good. If you haven't
Really? I'll
listened
have
to
to check
them,
that out.
yeah, they're pretty good.
I've listened to Kubla Khan. I don't know if I've heard the new one yet, but that's cool. I don't go to concerts that much. We get some good stuff here, but I saw Falling in Reverse, I think it was 2 years ago. I
Oh,
saw it was
nice.
them, Papa Roach, and Hollywood Undead. That
Oh,
was a good
wow.
show. Yeah, it was good. And then the one before that, I think I saw Godsmack and Hailstorm. They
Nice.
were really good. But yeah, I just don't get to go to shows much. We don't get much down. Closest thing is probably big shows would be Kansas City. I just don't get away to go. So
Yeah, oh, that's understandable.
yeah.
Awesome. So where can people find out more about you? Best website, and I know you've got some cool wrist wraps and all sorts of stuff going on.
Yeah, for sure. So I'm on Instagram and TikTok. I try to put out little videos about every day. So
TikTok, how's that going? I'm
it's
just giving you a
okay.
bad time.
The only reason I did that was just to get a different audience for
Yeah.
marketing my wrist wrap product that I created. That is the only reason. I am not a social media person, but yeah, I'm on Instagram and TikTok. Both of them are at the Morrissey Movement 33. And I do have a website. My fitness company is called M9 Maximum Performance. So m9maximumperformance.com. And then my wrist straps that I created, they're for track, so you can leave on your wristwatch, but still give you good support for heavy lifting. And so those are on Amazon. I launched back in March, and I've sold 111 as of today.
Oh, that's
So
actually pretty good for just launching on Amazon.
yeah, it's not too bad. I have a TikTok shop. No one's bought it. I think I sold one thing off there once. So I have 200 sitting in my house. So if anybody wants to buy them off TikTok shop, I'll ship them to you from my house. But yeah, it's going good. So I'm just slowly building the business. I got a guy that I'm working with that's making ads for me and doing the Amazon tweak things that I know nothing about. So sales are slowly starting to go up, and then I'll release a couple other products hopefully by next year once these take off. So all focused around split route design so you can keep your watch on and track your heart rate and your reps and all that stuff. So
Cool. And how do they find that on Amazon? What do they look for?
you can either do just M9 Maximum Performance, you can do split wrist wraps, and you should be able to find them. I'm the only That's the only one on the market actually. So there's that. I was first to market on that, which I was excited about. But yeah, so you can get them on there. They're $29.99 for on sale there. So that's what we had a little Prime Day sale, but that's over with. So I only had probably 7 or 8 sales on Prime Day, which wasn't bad.
That's not
So
bad though.
yeah,
Yeah.
for sure.
Cool. Awesome. Well, thank you so much for all your time here. I'd encourage everyone to check out all the great stuff you've got going on. I know you got a lot of stuff on Instagram, a fair amount, and appreciate all the good info. And thank you for sharing all your knowledge here. Really appreciate it.
You bet. Thanks a lot.
Awesome. Thank you, sir.
You bet. Thank you.
Good. Thank you so much for listening to the podcast. We really appreciate it. Big thanks to Tecton. Make sure to check them out if you're looking for a tasty ketone ester. Highly recommend you check them out. Yes, I am biased because I'm an ambassador and scientific advisor to them. We've got some great studies that are underway. A lot of work in the background to show that I believe this form of the ketone molecule is better. And you'll notice right away that it doesn't taste horrible. It actually tastes pretty good. Again, everybody's tastes are going to be a little bit different, but overall, I actually quite enjoy it, which I can't really say that much about any other ketone ester. And then also check out the Flex 4. Go to MikeTNelson.com/FLEX4 for my top 4 things I got from Dr. Chris Morrissey about the use of GLP-1 agonists. Also puts you on to the Daily Fitness Insider newsletter. And if you find someone who might enjoy this podcast, please forward it to them or share it on the old social media. Make sure to tag me so I can say a big thank you. And if you have time to tickle the old algorithms, give us some stars, whatever you feel were appropriate, or if you can even leave a review, those go a huge way to help the podcast move up in the rankings and keep us getting wonderful guests that we can bring to you. Thank you so much for listening to the podcast. As always, really appreciate it. Talk to all of you next week.
Well, they say all good things come to an end.
What's that got to do with this show?
This podcast is for informational purposes only. The podcast is not intended as a substitute for professional medical advice, diagnosis, or treatment. You should not use the information on the podcast for diagnosing or treating a health problem or disease or prescribing any medication or other treatment. Always seek the advice of your physician or other qualified health provider before taking any medication or nutritional supplement and with any questions you may have regarding a medical condition. Never disregard professional medical advice or delay in seeking it because of something you have heard on this or any other podcast. Reliance on the podcast is solely at your own risk. Information provided on the podcast does not create a doctor-patient relationship between you and any of the health professionals affiliated with our podcast. Information and statements regarding dietary supplements are not intended to diagnose, treat, cure, or prevent any disease. Opinions of guests are their own, and this podcast does not endorse or accept responsibility for statements made by guests. This podcast does not make any representations or warranties about guest qualifications or credibility. Individuals on this podcast may have a direct or indirect financial interest in products, or services referred to therein. If you think you have a medical problem, consult a licensed physician.